Welcome everyone, one and all of you joining us on Zoom from around Australia and beyond, and all of you here in this new auditorium at the University of Melbourne, including Dr. Anne Rickards, members of the Rickards family, and many distinguished guests. At the outset, and on behalf of us all, I acknowledge the traditional custodians of the place in which we're gathered, their elders, past and present, and thank them deeply for their grace in countenancing our presence here this evening. I thank their children and young people too for the inspiring example they provide to all of us of courage and creativity in the face of monumental challenge. I'm Suzie Dean, and I greet you all on behalf of Mental Health for the Young and Their Families Victorian Group, known as MHYFVic, to the Winston S. Rickards Memorial Oration. It's my privilege to greet also Professor Frank Oberklaid, who will deliver this, the 11th oration, titled "The Elephant Leaves the Room, an increased and belated focus upon policy and service reform in child mental health." This oration, as you all know, is, or most of you will know, is long awaited, having been deferred for 2 years due to COVID-19 complications. In 2019, Dr. Field Rickards and colleagues spoke on educational aspects of mental health for the young, and he is our respondent tonight. I will introduce him fully later. Organised and funded by MHYFVic, the oration is supported by other groups with which Winston Rickards was closely linked. These are the Royal Children's Hospital Mental Health Service, the Mental Health Foundation Australia, the Faculty of Child and Adolescent Psychiatrists of the RANZCP, Emerging Minds Australia, and the RCH Centre for Community Child Health, of which our orator was the founding director. We welcome all representatives and members of these organisations here tonight and thank them for their co-sponsorship. The oration is named for Winston Rickards, our founding president, whose interdisciplinary work in child and adolescent mental health was groundbreaking. Information about Winston's remarkable service is available from our outer desk, if you didn't pick that up on your way through. So we come to the oration. First, I will ask those present to continue wearing your mask. Thank you for that. And to turn off your mobile phone for the oration. At its conclusion, after 50 minutes or so, I will ask Professor Rickards to respond and then welcome general discussion for a brief time, including questions from our Zoom audience. Around 9:20, our president, Professor Joe Grimwade, will speak briefly about MHYFVic and conclude our event. We're not serving refreshments this year for COVID reasons, but gathering in the foyer is possible. After a brief photo shoot out the front here, our orator will be available to speak personally with you in the foyer. Professor Frank Oberklaid, AM, and I'll just do this. Professor Frank Oberklaid was the foundation director of the Centre for Community Child Health at the Royal Children's Hospital, Melbourne. He is currently co-group leader of Child Health Policy, Equity and Translation at the Murdoch Children's Research Institute. Frank is chair of the Victorian Children's Council, which provides expert advice to the Victorian Government on child health policies and services for children, and has chaired or been a member of numerous working groups at state, national, and international levels. Most recently, he was co-chair of the National Child Mental Health and Wellbeing Strategy. Frank's work has been recognised by a number of prestigious awards. He has been the recipient of invited lectureships and visiting professor appointments in a number of countries, and he is a consultant for the World Health Organization and UNICEF. An eminent paediatrician, Frank has long-standing clinical, research and policy interests in children's health, development and well-being. Professor Frank.
Thank you very much, Suzie. That's a good idea. I would also like to begin by acknowledging the traditional owners of the land, Wirinju people of the Kulin Nation, and pay my respects to elders past, present and future. Thank you for the honour of giving this oration. I actually knew Winston. I'm old enough to have worked in his department when he was still head of the department. And I can attest to the giant that he was in every sphere of clinical child psychiatry. He was one of the international pioneers in setting up child psychiatry around the world. And when I travelled overseas, when people found out I was from Melbourne, they'd always say, "Oh, how's Winston doing? And please give my regards to Winston." At that time, the department was a true multidisciplinary department, and I'll read out some names, and some of you may remember. Betty Wan, who was Deputy Director, Frank Bishop, Marcus Benjamin, Cynthia Edgell, who was Head of Speech Therapy, Pat Leeper, Head of Psychology, Eddie Keir, Head of Audiology, and all very, very impressive leaders in their own specialties in their own right. But Winston was the master, and to see how he related to children, his insights, the way he conducted assessments, the way he drew children and their families out was really quite remarkable. In fact, for a young paediatric registrar, as I was at the time, it was more than a little intimidating. And at some level, it may be one of the reasons I didn't end up doing child psychiatry, because I was quite attracted to it at the time, but I knew I could never get close to the levels of expertise that he had. But in addition to being such an iconic figure in child psychiatry, he had other impressive attributes as well. In those days, the residents and the consultants used to have an annual cricket game. And I recall very clearly Winston was a leg spin bowler, very, very wily. And you could never identify exactly what was coming out of his leg spin. So that was part of that sort of mystique as well, as a leg spin bowler, as well as a psychiatrist. But the other day I learned something that I didn't know, and that was he was a very good squash player. I was having dinner with a close friend of mine who's our family's GP, Tony. Hi, Tony. I'm sure he's watching. And Tony recalls that at one stage, 3 young registrars, 3 young bulls challenged him to squash. And he beat all 3 in consecutive games, one after the other. And Tony swears he didn't move more than 1 metre from the centre of the court the whole time. So this is what child psychiatry was like at the time of Winston Rickards. It was very much focused on the treatment of problems, had a very strong psychoanalytic as well as a pragmatic focus. And in those days, biological psychiatry was unheard of or very much in its infancy. And I can't recall any of the patients that I see or that were presented being on any sort of medication. And it was a time of what we call environmental determinism. You may recall autism was thought to be due to very cold, distant mother, the refrigerator mother. And behavioural problems were invariably seen as the fault of the parents. And I became very interested in temperament after reading a book by Alex Thomas and Stella Chess called Temperament and Development. And I recall talking to Alex at some meeting somewhere. They were two New York psychiatrists, husband and wife, who lived in the Upper West Side in New York. And the practice was largely middle class or upper middle class academics. And they had a very flourishing practice, but they were very amused by the fact that two children from exactly the same family, one had significant behaviour problems and the other didn't. So how could that be when they had the same environment, the same parenting? So they hypothesised that maybe the child's attributes contributed something to the child's problems. And Alex Thomas told me that when they first presented this at International Child Psych Meeting or an American Child Psych Meeting in the 60s, people were hissing because they couldn't believe it was so foreign to them. But at the time of Winston Rickards, the department also recognised the complexity of child mental health problems. So it was one of the first multidisciplinary departments at the hospital. But nothing stays the same, and child psychiatry evolved, and this is a paediatrician's view of its evolution. Biological emergency has evolved rapidly in the last couple of decades. DSM has become central and, to my mind, an over-focus on diagnosis, but DSM is held up as the Bible. Quote, new diagnoses and syndromes emerge, such as ADHD and autism spectrum disorder, increasing use of medications, and they're very widespread now in psychiatric practice, but also in paediatric practice, a much broader lens looking at child and family problems. So it's not nature or nurture, it's nature at nurture. And there was a new appreciation of the role of the environment, particularly poverty, and an acknowledgement by psychiatry and paediatrics of multiple risk factors and pathways to what we see as increasingly complex problems. In the literature, they're referred to as wicked problems. Paediatrics at the time of Winston Rickards was very different to what it is now. There was a focus almost exclusively on inpatients. When I came back from overseas, all the attention and most of the resources were looking after sick children in beds, because that was the traditional role of the hospital. And clinical practice was focused on diagnosing and treating disease. Prevention was unknown. Health was defined as an absence of illness. If you didn't have an illness, then you were healthy. And I recall a fairly unsophisticated view of behaviour and psychiatry. And you'll remember the old saying, if it's not organic, it must be emotional, and refer to psychiatry. So once we did the physical exam, we had a limited repertoire of skills and instruments to go beyond that. And the community was simply where patients came from. There was no focus in any policy around that. But paediatrics has evolved as well. And one of the leaders in the evolution of paediatrics was one of my old mentors. And some of you may recall that Bob Haggerty came to the Children's as a felt bequest visiting professor a long time ago, but he certainly had a very profound effect on me and my career. He wrote a seminal book in 1975 called Child Health in the Community, in which he argued that the community in which a child lives is a major determinant of his health. Although such statements are widely accepted intellectually, they're not yet reflected in our healthcare institutions. So this was 45 years ago. He also coined the term the new morbidity, because he argued that paediatric practice was changing. A group of childhood difficulties that we've termed the new morbidities gaining attention. Many of these difficulties lie beyond the boundaries of traditional medical care, and a major shift in the orientation of training programs. So this was at a time, if you recall, when paediatricians operated purely in health environments and hospitals treated disease. So since then, there's been an increased focus on prevention and early intervention, on the community, on family-centered practice, on early child development, the life course, adverse child events, etc., etc. And then not long after Bob Haggerty's time, I think it was in the 80s, but Jill will remind me if it wasn't, community child health emerged as a distinct specialty. And I still like this definition, a comprehensive system of healthcare responsible for promoting the health and development of all children within the context of their family and community, a much broader, all-encompassing definition of child health. And the clinical component of community child health is developmental behavioural paediatrics, which is the specialty of community child health. The definition goes on to say that community child health is multi-sectoral and multidisciplinary. So public policy and healthcare delivery for children must extend beyond health. And this is accepted very widely now, but in those days it was really quite radical. Different government agencies and different settings, hospitals, doctors, community nurses, etc. So a further broadening of the lens through which professionals looked at child health. And then paediatrics started to get more and more involved in behavioural paediatrics and in mental health. So in 1988, I published a couple of papers with the results of national surveys of paediatricians in Australia, where they reported seeing increasing numbers of children with developmental behaviour problems, and furthermore reported that their training was woeful. Their training did not equip them for the sort of patients they were seeing. The late Peter Hewson in 1999 published a year-long audit of all new patients in the Barwon area in Geelong, and found that 1/3 of all children were referred because of behaviour problems. The first National Mental Health and Wellbeing Survey in 2000, I'll talk about that in a moment, reported that children with mental health problems, particularly younger children, see paediatricians more often than psychiatrists or psychologists, and nothing has changed there. Daryl Efron and Jill Sewell published a paper in 2006 where they looked at referrals to the clinics in our centre, to the developmental behavioural clinics, and the children referred to the Children's Mental Health Service, and found extraordinary overlap, very similar profiles of patients. The difference was that we had 30 minutes with these patients and psychiatry could take their time. And then Harriet Hiscock in 2013, again surveyed Australian paediatricians and found that almost 50% of patients referred to paediatricians were diagnosed with mental health problems. So a real movement towards paediatricians getting significantly involved in mental health. Then in 1992, our college introduced a mandatory training period in community paediatrics. So this was interpreted initially fairly loosely, and there were some teething difficulties around numbers of training positions, but these are now resolved. And in Australia now, you can't become a paediatrician, a general paediatrician or a community paediatrician, without having undergone that compulsory training in developmental behavioural paediatrics. So in the year 2000, Michael Sawyer and his group finally got some national data on the prevalence of mental health problems. So this was the child and adolescent component of the National Survey of Mental Health and Wellbeing. And he asked 4 questions. How many children and adolescents in Australia have mental health problems? What's the nature of these problems? What's the degree of disability associated with them? And what are the services used by these children with mental health issues? And these numbers are quoted very extensively. 14% of Australian children had a diagnosable mental health problem using a reliable survey methodology. Only 1 in 4 of these children received professional help. Children aged 4 to 12 most frequently attended paediatricians and family doctors. Adolescents most frequently attended school-based counselling service. And only half of children with severe mental health problems received professional help, which is really sobering in view of the fact that over half of all adult mental health problems have their origins before the age of 14. So Michael Sawyer went on to say, and it's a long quote, but let me quote because it's very pertinent, the relatively large number of young people with mental health problems stands in contrast to the limited number of trained clinicians available to help them. This disparity makes it unlikely that specialised programs based in secondary and tertiary treatment settings, i.e. CAMS and departments of psychiatry, will ever be able to provide direct care for all those with problems. As a result, there is a need to develop alternative approaches to reduce the prevalence of child and adolescent mental health problems, experiment with alternative models of service delivery that combine direct care, consultation, and both universal and targeted prevention problems. So 21 years ago, there was the first call based on national data for looking at child mental health problems differently than the way we had done them. And this is Beverly Raphael's National Committee. This is published in 2000. And she concluded, while most of the impetus may come from within the mental health sector, it needs to be recognised that other sectors also have a major and explicit interest. Partnerships need to extend across all sectors of the community, including consumers, local communities, community groups, nurses, no mention of paediatricians. So this was my one critique of what I still believe is an outstanding report. She identified key strategic sectors and partnerships, 13 sectors, still no mention of paediatricians. And for the very first time, started to focus on outcomes. This is the first time I can recall anywhere in the literature that a national report like this said we should be measuring outcomes in child mental health as well. And she listed 6 there, and also 8 process indicators. Now, I don't know what Beverly Raphael thought of this report, but certainly, to the best of my knowledge, it gathered dust. It wasn't acted on. And it's worth, if you've got the time, to go back and read that original report, because you could perhaps change 10 or 20% of it. It would still be very relevant. So there were calls from 2 national surveys from Michael Sawyer's, this report, calling for a broadening of the lens of the way we looked at child mental health. So why has advocacy been so challenging in this area? And this is a quote from Leonard Sachs, an American psychologist, almost 40 years ago. Children's mental health problems reflect unique interactions between intra-individual difficulties and environmental conditions. Treatment must therefore address conditions in the family, school, and neighbourhood, as well as within the child. And he concludes, this requires a system with a diverse set of interventions and the capacity to coordinate multiple services. So those of us working in this area know that child mental health is a totally different country, and I've lost count of the number of meetings that I've been at and my colleagues have been at. We try and say child mental health is not the same as adult mental health. Child mental health is not the same as adolescent health. Child and adolescent is not the one word. So don't talk about mental health as child and adolescent mental health. So we know that children are dependent on others. The developmental stages mean that their emotional and developmental needs and symptoms vary with age. Those early years are very important in establishing the foundations for future mental health. There are untold opportunities because of the fact that young children and their families make contact frequently with universal systems in health and education. There are wonderful opportunities for prevention and early intervention. But this creates complexity. So there's a diversity of players, parents, childcare, preschool, universal services. Each of them has a role to play in identifying and referring and treating children with problems. But it's this complexity of child mental health issues that's contributed to just how difficult advocacy has been. We often use this quote from H.L. Mencken: for every complex problem, there's an answer that is clear, simple, and wrong. And governments are very challenged by complexity. Integrating policy across departments is very, very challenging. There's fragmentation, both vertical and horizontal, not just federal-state relations, but in responsibility for all those services that you've seen in those previous slides. So the federal government, the Commonwealth government, has responsibility for Medicare funding, for GPs, for childcare, but the state government has responsibility for education, allied health professionals, and so on. And prevention is a very, very hard sell because it's invisible. There are no photo opportunities, there are no announcements, etc. But in the last couple of decades, there's been other research, not directly in the mental health sphere, that to my mind has further strengthened the case for why we need an increased focus on children. And I'll briefly mention these: the brain development, the importance of the environment, the impact of stress and adverse child events. Each of those is a discrete body of robust research which points to the need to invest early in children. The neuroscience of brain development has emerged in the last couple of years as an uncontested and very robust body of research, pointing to the importance of those early years. That we know that brain architecture and skills are built in a rigid, hierarchical bottom-up sequence, and those foundations are important. And the brain is changed by the experiences that the young child has in those early years. And research is very clear about the characteristics of the environment that impact on outcomes, parenting, family functioning, communities. And what happens, as you know, the plasticity of the brain decreases over time and it gets harder and harder to change. So any of us that have tried to pick up a skill as an adult, whether it's a language or a musical instrument or a sport, you know how difficult it is. It's not impossible because the brain never stops learning, but it's so much easier if we would have started early. So the research is clear that biologically and economically, it's far more efficient to get it right the first time than to go back later on and try and fix things up. And what's important in Australia and other high-income countries, because we don't have challenges with nutrition or immunisation or safety the way that low-income countries do, is the quality of the relationships that a young child has with caregivers. Where they're nurturing and stimulating and responsive, that builds very solid foundations for future optimal development. But when those protective and nurturing relationships are not provided, then stress hormones rise in the child's brain, and that impairs significantly with brain architecture and future development. So dysfunctional relationships are a very major risk factor for future mental health problems. And any sort of adversity operating in that child's environment has that same effect. This is one of Harriet Hiscock's slides. Adversity comes in many, many forms, and every single one of these risk factors is more common in low SES groups. And psychosocial factors and adversity impact on health because of their association with high levels of stress, particularly in the early years. And where there's chronic stress, it resets literally the body's physiological systems, including the cardiovascular and immune systems, making that child, as he or she grows up, increasingly vulnerable to a whole range of problems through into adult life. And these are children that experience what we call double jeopardy. These are children whose families are stressed and disadvantaged, who would benefit the most from a good system of support services and live in communities where they're least likely to get it. These young children who would benefit the most from high quality childcare and tend not to go to childcare at all or go to poor quality childcare. This is Hart and Risley, famous longitudinal study where you can see the effects on vocabulary of disadvantage. You can see by the time these children are 3, there are very major differences in the richness of their vocabulary, depending on the family they come from. And remember what I said about the plasticity of the brain. It's unlikely that these lines are going to start to merge again. But we have our own Australian data from the longitudinal study of Australian children for social emotional difficulties, communication problems, vocabulary problems, and difficulties with literacy. We can see that problems start to emerge. Differences between high SES and low SES begin to emerge around about 2, 3, 4 years of age, well before the children start school. And this is the Australian Early Developmental Census, which used to be called the AEDI, and most of you will know that this is a population measure of children's health and well-being. Teachers complete a questionnaire with about 100 items in the first year of a child's formal schooling. We don't analyse the data of individual children, we aggregate it and analyse it for postcode, suburb, and so on. These are a bit dated, but still relevant in this high-income, prosperous country called Australia. Almost 1 in 4 children arrives at school developmentally vulnerable, and 11.7% arrive at school at risk of significant developmental or behavioural problems. In some communities, it's every second child. So these problems occur well before children and are identified before they start school, And what we expect school to do is to compensate for what happens in the years before children go to school. And it's a very challenging task. But these are the results by SES status. You can see the most disadvantaged children are the most likely to arrive at school in trouble. This is double jeopardy. The most disadvantaged children are the least likely to have a preschool experience. And this is a double whammy. So if they come from a disadvantaged family and don't go to preschool, then they've got a much higher chance of arriving at school developmentally vulnerable or at risk. This is Sharon Goldfeld's slide reporting on the second Australian Child and Adolescent Survey. You can see here this well-established gradient. Children who come from families earning more than $130,000 a year are half as likely as families earning less than $50,000 a year of having mental health problems. And then down here, you can see that living in the rural areas is also a risk factor because the services simply are not available there. This is the Adverse Childhood Events Study. In 1995, there was a retrospective study of 17,000 adult patients who had attended the Kaiser Permanente healthcare system in San Diego. And this group looked at the relationship between adult problems, not just mental health problems, a whole range of problems in adult life, and adverse events in childhood. And these were the adverse childhood events. They're pretty intuitive. So if you had more than 4 ACEs, more than 4 adverse childhood events, you had an increased risk of having poor health outcomes. But the strongest associations were these: risk-taking, mental health, alcohol use, etc., etc. And you can bet that these problems didn't suddenly emerge in adults. As I said before, more than half of the adult mental health problems emerge before the age of 14 years. So many of us get asked, I'm sure many in the audience get asked, why are we seeing such an increased prevalence of mental health problems? Is it an actual increase, or are we just more aware of it? Is it to do with higher expectations of both parents and schools? Is it that society is increasingly competitive? Is it media exposure? Is it social media? It's probably all of those. But what I want to draw your attention to is social climate change. Tim Moore from the Centre for Community Child Health has done a lot of work in this area. And he argues that the conditions under which families are raising young children is very different from what it was generations ago. It's more complex, it's less certain. There are changes in demographics, there's changes in compositions of families. Fiona Stanley used to call this a toxic environment for children. And poorly resourced families, that is children that come from disadvantaged families, are at risk because their families can easily be overwhelmed just with the challenges of daily life and parenting. And I think in our clinical practice, we've all seen examples of that. This is a quote from Dan Keating and Clyde Hertzman's book in 1999, 20 years ago, called Developmental Health and the Wealth of Nations, which is a very seminal book. And they called it Modernity's Paradox. We are witness to dramatic expansion of market-based economies whose capacity for wealth generation is awesome. At the same time, there's a growing perception of substantial threats to the health and well-being of today's children and youth in the very societies that benefit most from this abundance. And then a very articulate paragraph from David Green in 2013 in his report for Berry Street. It's not as if we've lost the knowledge of what has constituted a good childhood, but it seems more difficult to realize it in the context of rapid change. And we have limited ways of protecting, understanding, monitoring, and controlling the impact of progress on children. Shared cultural, political, and moral commitments to children are becoming confused, contested, and weakened in the face of the unstoppable changes, disruptions, and uncertainty. To my mind, that captures the environmental changes just beautifully. This is Harriet Hiscock's slide. There are challenges everywhere you look in a child and family getting services. There are challenges in particularly families recognizing there's a problem. I'll show you some data in that in a moment. When they recognise the problem, there are challenges in knowing where to get help. If they know where to get help, there are problems with access and equity, long wait times, high out-of-pocket costs. If they finally get care, it's fragmented. So children that have more than one diagnosis, and many children, perhaps most children with mental health issues, have multiple morbidities, the care they get is very fragmented. Then families and siblings often don't get what they need. And even if they do end up in good care, it's often inadequate, not long enough, not intense enough, and so on. This is Anthea Rhodes' data from the recent Royal Children's Hospital Child Health Poll, where they poll a random sample, a representative sample of Australian parents. And this one was on mental health. And these are her results. Over only a third of parents are confident they can identify the signs of mental health issues. That is, 2/3 of parents are not confident they can recognise a sign of mental illness in their children. Only half, or 44%, are confident they would know where to go for help. A third of parents thought that mental health issues were best left alone to work themselves out. A third of parents were unaware that primary school age children can experience depression. A quarter were unaware that children with mental health issues can present with physical symptoms. 1 in 3 parents didn't recognise that persistent sadness or frequent tearfulness is not normal. So it really points to a major gap in parent mental health literacy and parent understanding of the social and emotional development of their children. This is Harriet Hiscock's slide. Again, one of her students did what she calls a secret shopper study. She called the practices of 81 paediatricians, 48 psychiatrists and psychologists, and presented 2 hypothetical situations: a child with query ADHD, a boy with query ADHD, and a 11-year-old girl with query anxiety, and asked these practices about the waiting time and total out-of-pocket expenses. Even before we get to the results, a third of psychologists, half of psychiatrists, and 50% of paediatricians weren't even able to offer an appointment. That is, they closed their books. And this was 3 years ago. I suggest it's got much worse since then. So these were the waiting times. I'm very surprised it's only 2 months for paediatricians and 40 days for psychologists. Well, it's blown out hugely because of COVID now. But there are waiting times that have got worse. But look at these out-of-pocket expenses. So instantly you see a second problem, that is major issues of equity and access. So the service system is a system that's been under severe pressure for a long, long time. Long waiting lists. There's a focus on treatment of established problems, so opportunities for prevention and early intervention go begging. Access and equity, I've mentioned it. It's a very fragmented system. As part of our centre's efforts in mental health, one of our staff several years ago mapped all of the community services relevant to child mental health. And she identified 147 different types of services and programs. That's not 147 programs, it's 147 types. So she said there are literally tens of thousands of programs and services relevant to child mental health. So it's hard to navigate for professionals as well as for families. Any of us that have tried to refer a child, it's really problematic. CAMs have very high threshold for acceptance because they're under the pump. They can only see the most severe problems. Services get delivered in very narrow disciplinary silos. So there's a major mismatch between our service system and the multiple needs of children and families. And there's geographic variability. If you live in a rural or remote area, bad luck, the services simply aren't there. COVID has had a major impact on child mental health, not just increasing awareness, but increasing the prevalence of problems. So this first wave, you've all read around flattening the curve. Well, the infectious curve is largely flattened, but there's a second wave, second curve and a third curve. The post-pandemic phase, and this started during the first curve, was around increased mental health problems, family stress, parental mental health problems. But then there's a third wave, As paediatricians, we're very concerned about the future of these children who missed out on schooling for a couple of years, who lived in families where parents lost their jobs, where businesses went under, etc., etc. We don't know what the future holds for these children. And a major policy challenge for government is to develop a post-COVID recovery for children and families. So COVID had an effect on children with poor mental health and school attendance and so on, had an effect on families, had an effect on services. And we're aware that there are problems. We haven't even started to see the extent or the depth or how sustained these problems are. So to reduce mental health problems in children and to reduce the risk factors, we really do need a very major, in fact, a radical shift in public policy, focusing not just on treatment of established problems, but beginning to focus on promotion and prevention and early intervention. And that was the title of Beverly Raffel's report all those years ago. So we need to start to build a fence on the top of the cliff and stop ordering more ambulances at the bottom. Because we know that treating established problems is difficult and expensive, and it's simply not sustainable. So we need to focus on those family and community factors that we know, the research is pretty clear, that have a major effect, act as a major risk factor to development. And the earlier we intervene, the better. This is Dorothy Bricker's slide. If we intervene early, the cost of intervention is low and the efficacy is high. The longer we wait, the cost goes up and the effectiveness goes down. And most public policy, not just in this country, but in most jurisdictions, most public policy is to the right of this graph. That policymakers and governments wait until they can't ignore problems anymore, then throw money at it at a time when we know that the cost is very high and the evidence for efficacy and effectiveness is very low. I'm very attracted to Peter Drucker's quote. Peter Drucker was the father or the godfather, the grandfather of quality. He was an American who lived in Japan for many years and studied the Japanese system of quality processes, particularly the Toyota car company, and then came back to America and introduced continuous improvement into American industry initially, but then into healthcare. Drucker calls for organized abandonment of products, services, markets, or processes, quote, which were designed in the past and which were highly successful even to the present, but which would not be designed in the same way if we started afresh today, knowing the terrain ahead. So the old approach to mental health problems, and indeed to problems in children with developmental and behavioural problems generally, was we addressed the needs of the individual child. So my colleagues in the audience and I would sit in our offices and wait till patients came to us. We'd do the very best we could, but working by ourselves, that's a model that's 50 years old and hasn't changed a whole lot. We allocate resources only when problems become severe enough to warrant attention. The policies are focused on fixing individual deficits in individual children. The policy criteria is dollar amounts. I'm so tired of ministers saying we're a good government because we invested 20 million, 50 million, name the figure. The next time you see a press conference with any minister at the state or federal level in the social welfare or human services field, I promise they'll talk in dollars. Nothing about outcomes, nothing about what they're going to do. It's all dollar terms, as if because we invested $10 million, we're a good government. And services are delivered in very narrow departmental silos. The new approach focuses on populations. We're interested in improving outcomes for all children. We build on those very strong universal platforms we have that I mentioned before. Children go to maternal and child health nurses, they go to GPs, they go to childcare centres, they attend schools. There's an established infrastructure there that we should be investing very heavily in. We need a prevention and early intervention focus, a whole of government approach so we move away from these narrow disciplinary silos. We need significant flexibility at a local level. A one-size-fits-all doesn't fit. Every community is different in terms of its problems, its demographics, its service configuration. So we need the basics of a model, and then we need to leave it to community to organise services at a local level and hold them accountable. And we need innovative funding and accountability arrangements. I'll say that again, we need innovative funding and accountability arrangements, because the present system of funding children services, child and family services, acts as a huge barrier to optimal care. So we need to move away from this reactive individual approach towards a population prevention approach. Or represented another way, we need to move away from a focus only on these children that have problems. If you look at child mental health or child protection issues or any of the major problems in children, the focus has always been on treating children with problems. And it's unsustainable. We've seen resources poured into child protection, for example, and it's still an issue. This is not sustainable. It's not the way to go. We need instead for policy to be informed of what we call curve shifting approaches. That is to say, we need to invest in the whole population, looking at risk factors, looking at prevention, etc. And if we do that, the whole curve moves over to the left. And that's the way we reduce the number of children with problems. This is a slide that I developed a number of years ago to try and represent on one page this broad lens that we need for child mental health, and try to move the focus away from treatment of established problems, away from the tertiary care. So in an ideal world, we'd start by focusing on families. We'd make sure that families have good mental health literacy, and that they have ready access in an equitable way to primary care services. And the primary care services, the universal providers, would spend some of their time improving parent mental health literacy. Primary care services, the universal services, would then be able to make informed referrals in a way that is accessible and equitable to all families, to secondary services, secondary, tertiary, etc. All that would be underpinned by workforce development. That is, making sure that all of these providers have the skills and the capacity to do what they need to do. And already we're seeing significant shortages, workforce issues, shortages of MCH nurses, speech pathologists, pediatricians, psychologists, psychiatrists. And you can't just click your fingers and suddenly double the number of psychologists or double the number of pediatricians. This has got to be a long-term view. And we're only now starting to see evidence of planning for that. So there needs to be proper resourcing. We need to focus on place, because every community is different. And importantly, we need data. We're so lacking data. In a hospital system, we sneeze and it appears on a database somewhere, and funding is allocated on very, very sophisticated data. In the community, we're in the Stone Age in terms of collecting data. And you know, the old saying, no data, no problem, no solution. So there are good innovative approaches all around the country. I'm sure there's emerging minds and there's BU, etc. But because I'm from the Centre for Community Child Health, I just want to, towards the end of my talk, give you some examples of some of the innovative work that we're doing here. We're working on a continuum for child mental health. This is a very, these words and the way it looks has moved a lot since then. Vicky Leone is in the audience. She's a wizard designing and so on. But we're trying to get away from needing a diagnosis to get services. And we're trying to address stigma. So parents don't need to worry, does my child have autism? Does my child have ADHD? All they need to know is their child is struggling in some way. And similarly for GPs and MCH nurses, we don't want to turn them into diagnosticians. But if the child is struggling, that's enough reason to get help. So we want all children, obviously, to have good mental health. Inevitably, as a child goes through life, he or she is going to have little hiccups. We hope that they'll cope. And the role of teachers and parents is to help build resilience, to help them cope with the vicissitudes of life. But we also know that some children are going to start to struggle. And our challenge, and the challenge right through the universal system, is to identify those children that are struggling as soon as they start to struggle and build scaffolding around them to get them back to coping. and to try and avoid these children that are having severe mental health problems that need tertiary services. We've been working for a long time on child and family hubs with limited advocacy success. These are not mental health centres, these are child and family hubs. And our vision is that we build on the existing community health system. Victoria's got a very good system of community health centres, that there's a multidisciplinary core team with expertise in paediatrics, child development behaviour, that there are clear coordinated pathways from primary to secondary to tertiary, that it's integrated with the existing system, it's built on local services. These are not necessarily new things introduced into the system. It's building the capacity of what's already there, a focus on access and equity, addressing parent mental health literacy, building capability, and very strong and seamless links with the quaternary system, with child protection, with housing, family violence, and so on. And this is the representation, so anybody can refer in, parent concerns, primary care system, educators, etc. They're triaged at the front door, somebody with skills who triage them according to what the presenting need is. And it may just be reassurance your child is doing fine. It may be a referral to the Raising Children website, or it may be come in for a proper multidisciplinary assessment because this child has severe problems. This is a project that I and some colleagues are involved in, looking to build capacity in schools for mental health. So we know that schools are an ideal non-stigmatizing problem because most children attend school. Teachers spend about 1,000 hours a year observing children. They come to see a paediatrician like me, they might get 9 hours a year. I think that's generous. They get an hour, then maybe another half hour, etc. So we have these skilled professionals in a situation where they observe children in lots of different settings, in class, in the playground, the way they socialise, etc. So the potential for schools of delivering intervention is profound. So the goals of MIPS, as we call it, is 3, to build capacity within schools to detect problems. So they'll work with classroom teachers to help them identify emerging problems, to delineate a clear internal and external pathway for children that teachers pick up, and then use these referral pathways to build bridges between education and health. So part of this role is to identify community-based resources and make informed referrals outside the school. So the training, we've done this in partnership with the Melbourne Graduate School of Education, Field's old department, and we train experienced teachers to develop a new role, which we call an MHYFVic, a mental health and wellbeing coordinator. So our training program is focused on improving knowledge, improving skills, making sure that they've got the right attitudes. So the first year we did a feasibility study of 10 schools. Last year we did 26 schools, and we're halfway through the evaluation. This year we're doing 100 schools, and the early evaluation data are very, very exciting. This is a couple of Harriet Hiscock's studies. This is a community of practice where she organised a number of clinicians from different backgrounds to come together as a community of practice, which for those of you that don't know the terminology is simply a network of professionals, often geographically based, but just having a common interest. And then a child psychiatrist do a formal 1-hour didactic presentation on these sorts of topics. And then the resources were sent to all those participants. And again, the evaluation data are very, very promising. This is a model that could be replicated in every single community around the country. It's such a good use of psychiatry time to do teaching instead of just assessment. But where's the funding come from? Medicare doesn't allow for this sort of practice. Again, another one of Harriet's studies, liaison psychiatry personified, 22 consults to a psychiatrist. The psychiatrist made himself available not just to see patients, but to provide liaison consultation to GPs and paediatricians by telephone or face-to-face or email. And all of the patients, the 22 consults, not one was referred to CAMS. In other words, The psychiatrist used his skills to empower and increase the expertise of the referral. This is another great example, but again, major hindrance in our funding. So is the elephant actually leaving the room? Well, there's certainly increased policy attention in the last few years to child mental health. Productivity Commission, the Royal Commission, the National Children's Mental Health and Wellbeing Strategy, and in one of the outcomes, I'm not sure it's a benefit, but the child mental health the awareness of child mental health has been significantly amplified by COVID. So suddenly it's in the media, people are talking about it, people are concerned about it. The Productivity Commission was the first major report. It reported in 2020, and it's a pretty good report. We could quibble with bits of it, but they got the major direction of it right. A focus on prevention and early help, early in life, early in illness. Families, schools, seamless care, etc. So they addressed some of the concerns we've had for decades around the mental health system. They identified gaps and barriers that needed to be addressed, a narrow view of people needing support. That is a very narrow lens through which they looked at child mental health, underinvestment in prevention, focus on clinical services and overlooking other determinants, difficulty finding, accessing support, below best practice, stigma, dysfunctional approaches, duplication. So they're all concerns that have been, these aren't new, that reports going back 20 years, like the report of 2000 that I mentioned, all identified those. And then the Productivity Commission identified some priority reforms, again, prevention and early intervention. Victorian Royal Commission, there's some interesting data. Significant gap between demand and actual hours of community-based specialist mental health services. In the year 2020, they estimated there was a need for 539,000 hours of specialist mental health services, and only 45,000 was delivered, so less than 10%. So that gives you an indication of that hard edge. We're not talking about children with mild problems that are picked up at school. We're talking about children with established need for specialist mental health problems. Then the National Children's Mental Health and Wellbeing Strategy that I was co-chair of. Just a few words about the process, because it really was an exhaustive process. Under the auspices of the Mental Health Commission, we had a multidisciplinary expert advisory group, 2 working groups, 0 to 12 and 5 to 12, as well as an Aboriginal and Torres Strait Islander group. We had a national steering committee, which included state governments, very extensive stakeholder consultation with professionals, with colleges and associations, APS, College of Physicians and so on, College of Psychiatry, and then consultation also with people with lived experience, with vulnerable and at-risk groups. So the whole process was very comprehensive. And we landed on 8 principles. These are all motherhood principles, child-centered, strength-based, prevention-focused, etc. They're very hard to argue with any of those principles. And then we had 4 focus areas, as you can see there. And we had a very interesting debate whether the first principle should be the service system because it's such a mess, or family and community. And we landed on family and community because we wanted to send an important message about the central role that families provided. And also that provided a clear message about the importance of prevention and early intervention. Then for each of these 4 focus areas, we had key objectives and actions and indicators of change. So again, we wanted to emphasize that we needed to measure this. We needed both to implement it and then measure it and keep on tweaking it, not set and forget. So this is, I think in the last page, this is what we said. The strategy proposes a number of actions that collectively represent a fundamental cultural shift in the way we think about mental health and wellbeing for children. A change in language, a change in status, a change to ensure access and equity in all systems, a change towards needs-based access to services, not diagnosis-based, and importantly, a change in the collective understanding of the roles of families, community services, and educators. But as my colleague Don Burke says, nothing hard is ever easy. And there are some challenges in implementation, and these are some of the concerns that we have. What we don't want after all that work and after the replication of the recommendations made in previous years, we'd be really disappointed if this just gathers dust on the shelf. So we're concerned that success of this strategy will be measured simply by the amount of new funding. We allocated X $100 million to child mental health, tick, that problem is solved, rather than a fundamental reform of the whole system. We're concerned about that we focus on short-term rather than a 10-year evolving plan. We see this as a sort of practical roadmap that'll take at least a decade to implement. Fragmentation, I've talked about, of funding, of policy, of implementation, federal state differences on priorities as to where they go first. Reform fatigue, constant reform is exhausting. We're continually arguing for change and coming up against entrenched interests. Solutions are too complex, that governments will revert back to traditional funding of narrow programs. This is a constant fear that child mental health is seen through an adult mental health lens, so diagnose and treat, rather than a child development and family perspective. We're worried about set and forget, that funds won't be allocated for evaluation, or if they are, it'll be 5 years afterwards as an afterthought, and it'll go to KPMG or one of those big companies. And again, we're worried that it'll be crowded out by adult and adolescent mental health. But both adult and adolescent mental health have very pressing issues. We're not for one moment diminishing how important they are, but so is child mental health. But there does exist now a window. 3 reports, concerns amplified by COVID, people mostly on the same page, the national strategy saying the same thing as the other reports said, and the report said 20 years ago. So we do have a window. And Don Burke, again, our colleague, says, and I quote it, "The burden on good leadership to make the currently unthinkable thinkable, to question the obvious, to make the present systems unavailable as options for the future. The boundaries in our minds create fear about the consequences of crossing over to the undiscovered country. But the possibilities we really need do not lie on this side of our mental fences. Once crossed, these fences will look as foolish in retrospect as the beliefs of other times now often look to us." Thank you.
Thank you very, very much, Frank. Now, I know people will want to ask questions or make some comments, but first, let me introduce Professor Field Rickards to respond to your excellent presentation. In keeping with our custom, our previous orator will provide the response to our oration tonight. The 10th oration was almost precisely 3 years ago. Professor Field Rickards and colleagues, Associate Professors Lisa McKay-Brown and Peggy Kern, presented Mental Health and Schooling, the Education Challenge. They reminded us that the academic success of young people at school and beyond is inextricably linked to healthy social and emotional development. Now, Field is the nephew of Winston Rickards and is enjoying now his 49th year at the University of Melbourne. He concluded 13 years as Dean of Education in August 2017, and the university awarded him the title of Dean Emeritus for his sustained and transformative leadership. Since then, he has been a professorial fellow in the Melbourne School of Government and is co-director of the Assessment, Curriculum and Technology Research Centre based in Manila and funded by DFAT, with a clear focus on education transformation in the Philippines. Theo, please come to the podium and give us your thoughts.
Thank you, Suzanne. Well, Frank and ladies and gentlemen, what an extraordinary tour de force, Frank, we've had the privilege of hearing. I'm pleased to have this opportunity to be the respondent of this, the 11th Winston Selby Rickards Oration. It's not new, you said, Frank, a few minutes ago. Indeed, in 2004, Frank, you wrote a commentary in Paediatrics, the new morbidity in education, which you referred to the paediatrician's role. If I could just quote. It's now almost 30 years since Haggerty described the new morbidity in paediatrics, and developmental and behavioural problems became part of mainstream paediatrics. Paediatricians involved in the management of children with organic disease would frequently seek the assistance of biochemists, microbiologists and radiologists. In a similar way, paediatricians involved with conditions that compromise this new morbidity need to work with educators, with psychologists, with speech pathologists and other allied health professionals, just as Winston saw. In the same way as biochemists, radiologists and microbiologists are considered essential in the management of sick children, those with an organic disease, in the management of sick children or those with organic loss, so are the allied health professionals considered essential for assessment and management of children with learning and developmental disorders. Indeed, one might argue that their role is even more crucial. It's not new, is it, Frank? Because many of the interventions are implemented not only by paediatricians, but also by other professionals. Then you went on to say that for school-aged children, the teacher's role is central. Often they are the first professional to identify a problem and suggest paediatric assessment. Finally, the teacher's role in implementing recommendations may follow assessment and monitoring the child's progress, and that's vital. It follows, therefore, that good communication and shared understanding between health and education professional is very important. That's where you and I had many discussions. So in that same year, 2004, as you've just heard, I was appointed Dean of Education. Frank and I went on to convene the Education Health Reference Group, which broadly considered the multidisciplinary management of the broad range of children with additional learning needs. Our collaboration across the health education interface, as we called it, Frank, has extended for more than 20 years and has been facilitated through our contributions to the Royal Children's Hospital, my contributions through the Royal Children's Hospital Education Institute, ours, the research collaborations we've had at MCRI and CCCH, and our love for our respective football clubs, Frank. I won't expand on the last point, but I'm still waiting for that phone call following the 21 grand final. So it's not surprising the topic of the last oration was about mental health and schooling, as you've heard, noting the same prevalence that you've quoted. 1 in 7 4 to 17-year-olds have mental health disorders in the previous 12 months. So I noted then that it's not just a health issue. It's an educational issue as well. In the Aspen Institute, and you've just heard this, said the evidence base on how we learn is that social, emotional and academic development are interdependent competencies. And if one of those is down, the others will also be down. So as I said, it is more than a health issue. So schools do play a central role, and I think that very much fits in with your long strategy. So Frank's oration gave us deep insights into the complexity and challenge of mental health issues. He posed several reasons why we're still having a long way to go. And if you add Haggerty to your 20 years, Frank, and beyond, we're talking about 50 years of still trying to address the problem. So some of the things you highlighted, Frank, without rehearsing the entire 87 slides, but things that I think highlight the points you're making. is that it is multi-sectorial, it is multidisciplinary, the whole nature of mental health, and that public policy and healthcare delivery for children must extend beyond just health. The challenge of multiple government agencies include health, welfare, education, housing, law. They all have an involvement. And there are different settings for detection, for referral, and for intervention. Second, you talked about the importance and introduction of training for paediatricians in mental health and community child health. And you referred to the National Action Plan of 2000 and noted the 13 sectors and tongue-in-cheek that paediatricians weren't mentioned, although I'm sure it was implied. But you posed the question, why has advocacy for child mental health been so challenging? And noted that it's a unique interaction between intra-individual difficulties and environmental conditions, that is family, school, neighbourhood, and treatment must address both of those. It is this complexity that's contributed to the relative lack of policy attention, you noted. In quoting Mencken, quote, I love this quote, for every complex problem, there's an answer that's clear, simple, and wrong. As Frank said, governments don't like complexity, and policy across departments is challenging. Frank noted the impact of the socioeconomic status and through the Australian Early Development Census Index, and indeed the participation in preschool is an important preventative factor. He went on to address the question, so why are we seeing an epidemic of child mental health issues, and posed a number of hypotheses? And then went into detail of the challenges that needed addressing, including distinguishing the mental health issues by clinicians and by families, where to get help, long wait times, fragmented care, supports for families, and adequacy of care. So there needs to be a major public shift, as you said, Frank, focusing on not just treatment, but on promotion, prevention, and early intervention. A shift is needed from the needs of the child being dealt with in isolation to a focus on populations with universal platforms of community focus. Frank concluded his oration listing the gaps and barriers that need to be addressed. And these have all come together in the National Children's Mental Health and Wellbeing Strategy that was published last October. With Frank, of course, as the co-chair and Crystal Middledorp as the other co-chair. And you mentioned the 4 areas of focus: family and community, the service system, education settings, evidence evaluation. This is Australia's first national children's mental health and wellbeing strategy, and provides the framework and foundations for lifelong mental health and wellbeing to be built during childhood with a whole of community approach, and a framework for our nation's mental health reforms. We all, Frank, do hope that this strategy gets the national acceptance and has the impact that you have sought for several years. Frank, congratulations on this significant achievement, that is the report, but also on the wonderful career so far, and reflecting on your excellent and reflected in your excellent Winston Selby Rickards oration tonight. So thank you for honouring Winston and his pioneering work in the way that you have tonight. So I now hand back to the chair. Thank you.
Thank you, Field, for your insights and for getting our discussion rolling. I now invite people in the audience to make a comment or ask a question of Frank. Now, there are 2 roving mics here for the live audience, and we hope we can respond to you if you're on Zoom too. You just type into the Q&A section on your screen, and our moderator here, Dr. Cecilia Winkleman, she can read out your question to Frank. Frank, would you like to come up here? So while you're just thinking about it, I've got a question.
Thanks, Frank. Paul Robertson. There are many challenges in sort of trying to take this forward. Maybe one of the immediate ones is how to develop a capable workforce and get that trained. And I wonder if you've got thoughts about how that actively gets built into the system rather than just hoping it happens and the workforce is there when it's needed.
I have no particular insights that you don't have, Paul, but as a paediatrician, I don't have the opportunity of picking your brain, for example. You know, we're lucky we work in a hospital, and I suspect many paediatricians have developed these informal relationships where we can pick up the phone and speak to one of our colleagues and get informal consultation. So we need a system where that expertise keeps on getting pushed down. So GPs should be able to call paediatricians should be able, et cetera, et cetera. But that's a short-term solution, but somehow we need to build this into our pre-service training. Melbourne Graduate School of Education needs to have more mental health training. It needs to be built into general practice. Somehow we have to make space for child mental health, family issues, etc., into all the allied health professional training. It's got to be a 5 or 10 year plan. And the problem is, as it's been put to me, that governments can't influence universities. For example, there's a huge shortage of early childhood professionals. And Melbourne University has the capacity to increase the numbers by 3 or 4 or 5, but they've got to make that decision, and then the government has to provide those incentives. When we spoke to the Australian Psychological Society, they said to us, there's a great shortage of child psychologists, and the reason is that the people doing the training in academic centres are adult oriented, so that they don't get exposed during their training to child psychologists, and there's a shortage of community places for them to get supervised. So it goes right across the system. And I don't know who's accountable and who's responsible. The APS is an independent organisation. State government is responsible for some training programs. Federal government is responsible for childcare. Who stands up and leads this? You know, we really do need an integrated workforce strategy. I know that Department of Education and Training has a workforce strategy. I presume Health does as well. But it's pretty transparent. I haven't spoken to any of my colleagues about it. Maybe they've engaged you in the college, Paul, but I suspect probably not. So it's still in bits and dribs and drabs. Ask that question of the Federal Health Minister or the State Health Minister. But someone's got to be tying all of this together. One of the recommendations, the RACP has got an advocacy program now for a post-COVID focus on children. And one of their recommendations is for a chief paediatrician in Canberra. Now, whether they accept that or not, we've argued unsuccessfully for that before, but somebody who's got a broad lens and has some authority, has to start to pull these threads together. Otherwise, in 20 years' time, we're going to have a new report and somebody else will be sitting here talking about the same sorts of things. That's a totally unsatisfactory answer, but that's the best I can do for it. I remember when we met with you in the child and adolescent section of the college, do you remember? And I remember clearly what you said, that child psychiatrists are terribly frustrated sitting in their offices with the impossible problems they've got to deal with. It was either you or one of your colleagues said you would love to be out teaching paediatricians and others. Do you remember you said that? So how do we break that nexus? It's not just resources, it's got to be some leadership, not just by your colleagues, not just by our colleagues, but we really do need some political leadership. And I think the opportunity for us, because I think most of us are on the same page, is to have a coordinated approach after the elections to say, look, here are all the colleges, all the associations, all the professional training organisations, the universities, this is what we need on one page in order. One of our staff used to say, for policymakers, it's got to be simple as add water and mix. Anything more complicated, it's too hard for them. And the other problem is 3-year terms. You know, governments don't want to take the risk. So there's the first year of government, they're putting their feet under the table and finding out, you know, making new appointments. In the 3rd year, they're in election mode. So you've got 12 months of action. Pretty challenging, but I'm optimistic, I think.
Frank, earlier in the talk, you contrasted the style and paradigms used by Winston Rickards in your registration psychiatry department with more recent approaches to child mental health problems. And amongst your list was this DSM push towards categorical diagnosis. Can you tell us what you think's lost or what we miss when we put kids into these categories? I think you talk about autism, the rubbish bag, the anything.
That was a Dorothy Dixon, because Daryl and I have had these conversations as with Harriet and Jill. I think the DSM, this is heresy, but it's a personal opinion, and at my age I can say things like this. I think the DSM has its advantages but has significant disadvantages, and it's driven a lot, in my opinion, by the American healthcare system. If you're a pediatrician or a psychiatrist working in the States, you cannot get reimbursed by a health insurance company unless you put a diagnosis there. So that's part of the problem. But it seems to me that every child that's got any sort of minor problem when it comes to a pediatrician, we're looking for a diagnosis to put that symptom in. And the number of diagnoses is expanding all of the time. And there's not a whole lot of science behind DSM, really. So in 3 or 5, we're at DSM 5, they're probably working on DSM 6 now. And you can bet there'll be a whole plethora of diagnoses. And the sort of kids that we used to see, Jill and I, the older states people of the centre in the old days, and you guys saw them as well, the child would present to us or to our trainees with some concerns about learning and some self-esteem issues. And yes, they're a bit distracted in the classroom, and we have to work it out. And so, yes, the child had attention problems, maybe secondary to the fact that but you describe the problems. And my old mentor in the States used to say, prescription follows description. If you can describe a child accurately, strengths, weaknesses, family issues, the prescription falls out. Yep, this child needs some help with language. You may consider medication for the attention problems. Now they look for a diagnosis. So does it help these kids when our colleagues do a 30-minute consultation? Yep, he or she fits the criteria for X. The prescription doesn't fall out. So what? You still have to work out what to do. And one of my particular bugbears is the notion this child does not meet criteria for the condition. So he or she has 5 out of 9, not 6 out of 9, therefore no diagnosis, therefore no NDIS, therefore no treatment. And the example that I always use, which is a little naughty, is postnatal depression screening. You know, I think the Edinburgh cutoff is 10 or 11, Harriet, remind me? Okay, thank you. So a mother's feeling depressed, goes to the GP or a nurse, they do the Edinburgh, they score 8. Oh, you don't meet criteria. Oh, thank goodness, I thought I was depressed. It's just not helpful. So children that don't meet criteria still need help and support. So I think it does kids a terrible disservice. And the concern is that less experienced colleagues are drawn into this diagnosis because teachers want it, because they get services. Parents sometimes want it. So I'm not saying don't make a diagnosis, but I'm saying we need to be flexible. We need to be sensitive to the needs of children as well. For some parents, making a diagnosis frees them up to be good parents. Well, I knew there was something wrong, and then you can work with the parents. But for others, an autism diagnosis is like a cancer diagnosis. As soon as they hear the word autism, that's the end. They don't hear anything else that you say to them for the rest of the consultation. So there needs to be balance. Your response, Darren?
I have a question at the back here, and then we have one on Zoom, and I have 2 down the front here. There are lots of questions. Anna.
Anna Correa. You mentioned allied health many times. Wonder if you could say something about social work profession, and have you had some collaborations with them and how they might be part of contributing to the bigger scheme?
Well, I think they're an important part of the multidisciplinary team. You know, we're seeing the change for Jill and I, and probably for the younger colleagues as well, in the last 2 or 3 decades. We're seeing kids with much more complex problems than we used to see. We rarely see a child where we can sort things out very quickly. And what's changed is the complexity of family issues, not just because of disadvantage and poverty and so on, but there's such complexity in some of the presenting cases. We did a telehealth consultation with 6 schools in rural Victoria, and 5 out of the 6 schools, the family was the issue without any question. And I remember finishing and saying to my colleagues, you know, we're training a mental health and wellbeing coordinator in schools. What each of these schools needs is a social worker. So I think they're a very, very important part of the team.
Thank you. I now have a question from Zoom.
Well, the first one is a comment from Rachel Chiodo. It seems important to highlight the importance of play, of the arts, and of sport to our children's and families' mental and physical health. COVID interrupted so much of this, and it seems timely to remind ourselves of the protective nature of these activities for children and their communities.
So can I ask Jill Silver to comment on this? One of Jill's major advocacy campaigns now is about the importance of play. Sorry to ambush you like this, Jill.
Do you want to come on?
Yes, I'm on a bit of a journey at the moment to do exactly that, to think about the importance of play to improve children's health and development and mental health well-being, but not just about children's play and not just about those sort of more direct components that we've just talked about and that the question was about. It's about, or the comment was about, it's about play and creativity being a really important component for all of us at all stages of life to improve our health and well-being. But for children in particular, play is their work, play is their learning, play is their development, and play is their joy. And I think children have lost a lot of capacity and access to the sort of free and unstructured play, which does them so much good. So I want to try and change that emphasis in health settings, but also in the community overall, because I think it's absolutely critical to childhood outcomes.
Thank you, Jill.
Another?
Would you present another question?
Yes, this is from Jackie O'Brien. In this election year, 2 elections, in fact, for Victoria, you have noted Drucker's organized abandonment and the need to move to new models. How do you suggest, with all the data, science, and practice wisdom that we have, raise the profile to politicians to commit to a bell curve shift and get funding for the new model of care you outline in the child and family centers?
I take that as a rhetorical question. I just want to acknowledge my colleagues here, Jill, Daryl, Sharon, and Harriet. We've been on a journey for longer than we care to remember, trying to push that. And we've supported each other, learned from each other, argued these things forever. And I can't say that we've been particularly successful in our advocacy. We've had some little wins, but the bulk of our advocacy has been unsuccessful. So I'm afraid I just can't answer that. Any of you like to? Harriet.
Give it a go. I work a lot with health economists and money does speak. And so I think combining our data with the economic argument is one way to go. I sit on the Medicare Review Advisory Committee, and one of the things the Productivity Commission recommended was an item number for paediatricians and GPs to be able to speak to psychiatrists. Doesn't exist yet. But if we can present the data to MRAC and they approve it, then we start moving towards these models of more integrated care, because as you said, Frank, the funding system just stops that at the moment from happening. So it's one piece of the puzzle, And I think with the hubs coming up in Victoria through the Royal Commission, which are quite mental health focused at the moment, Paul, it'd be interesting to hear your thoughts on the hubs and the workforce in the hubs. There is an interest in this now with the state government at least, and we've got an opportunity to have these 3 hubs in Victoria for children really representing integrated care. And I work with the health economists, so thinking about the funding models to enable that, because it's not Medicare fee for service.
Thank you. I'll take this question in the front row here now. If you come around here.
Joe Grimwade. I'm much less happy with this progression that we're going through. It seems to me that as a child psychologist, there are no child psychologists of any strength or quality emerging from our educational institutions. And I spent 25 years trying to do that. So I find that really very sad. I mean, I think the Medicare solution to all of these problems is actually not the solution, because it always individualises and it always reduces complexity. And in particular, with respect to psychologists, it's meant an exodus into private practice of psychologists who have 2 years' work before they've even cut their teeth. They're going out and working in private practice. It is a terrible situation. And I think that's a sign of something that's been happening for 20 years. It seems to me, when I was in child and adolescent mental health back in the late 80s and early 90s, there was a sense of actually people collaborating, working together in multidisciplinary teams. And I'm afraid every government move in child mental health has been has attacked the multidisciplinary team and collaborative work. And it's very sad. It is just counterproductive. And there's one other point that I wanted to make, and it's now slipped my mind. We need to come back to this. I don't know how we can come back to it. I think it's generational. I don't see people breaking down the doors to be part of our multidisciplinary force that is MHYFVic. I don't see that there's anybody joining us. You know, I'm the youngest on the committee. I'm 66, and we want collaboration. We are collaborationists, and we're dying out. And I think that your very hopeful plan for interdisciplinary and multidisciplinary work is probably 10 years too late.
Ros.
Ros Webb. I was at the Children's Hospital when Winston was director, for part of the time he was director, and he was aware of the complexity, and his department was made up, as you noted, of so many different disciplines, because he recognised the importance of the interactional approach, and also reached out to the community, you know, and schools. That was all of that was a very big part. One of the things that wasn't mentioned, and I want to put a bit of a rally call for this, because I think it's relevant. I was speaking, just making some mention to Paul earlier about talking to him about this, which links in with what you're saying about training and the workforce, and also support. I think it's support of the workforce as well. But there was also a child psychotherapy department, which was part of the Department of Child Psychiatry at the time as well. And when you said no paediatricians were mentioned, there was also no child psychotherapists mentioned. And Victoria happens to have developed the peak body of child psychotherapy, which does take account of all the complexities that you're talking about. It's not just in the room. And in contrast to a lot of other practitioners, there's quite a high percentage of child psychotherapists who are working in public sector areas and also training other professionals. So I actually want that to be thought about and integrated in the program. And I totally agree with all the things that you've said. And I don't think that it necessarily does need to die. I've just one word that comes out to me from that too is systems. This is all about integrating systems, approaches, and having that vision. And I understand that the Victorian government is, developing community, which is also in line with what you're saying, community-based services, where I think there can be a lot of input from the professions we're talking about into those areas where, to help train up. But it's also helping these organisations or services to understand the dynamics of what's actually going on in the services as well. And I think that's another area that psychotherapists can contribute to.
Would you like to comment on that, Frank?
No, I'll just take it as a comment. I don't disagree with you.
Okay, I'll have a last comment here. This is for Maurice Eisenbrook. Congratulations on your tour de force, Frank, your encyclopedic review of over half a century of child mental health. In your material, you included a list of disciplinary professions in which psychology appeared as last in the list. Curiously, the discipline of child psychiatry was conspicuously absent. Later, you mentioned a 1-hour formal lecture by a child psychiatrist. My question is, in the same way as the elephant has left the room, has child psychiatry become the dinosaur in the room?
The answer is absolutely not. But we don't get to see them all that often though as paediatricians, because it's hard to get a psychiatrist to see our kids. I mean, the threshold, as you know, Paul, is getting higher and higher and higher. We've all had extraordinary challenges trying to use all our relationships and to try and twist our colleagues' arms to get a child seen. It's very challenging because they're up to the next seeing really, really severe problems. I would love to spend more time with child psychiatrists. I'm sure my colleagues would as well. But you've got to somehow prevent that huge workload they have looking after wicked problems. So if Morris felt that they were last and that they're dinosaurs, then I apologise. That's not the intent at all. I think all of us would love to spend more time with child psychiatrists. That's an invitation, Paul. Come and hang out with us anytime you want.
Just entertainment. I've probably taken more lateral moves since you first influenced us, but I have to say your work has influenced me throughout my career, so thank you. My question is around, with all the advocacy that we might make, how do we stop things being undone? I mean, you'll remember in the 90s we had early intervention, which was universally available, no wrong doors. We had school support centres for about 10 years, if I'm right, where we had multidisciplinary teams that served a number of schools, and yet politicians came and dismantled those. I mean, the most recent one, which I think is also an elephant in the room, is child disability, and whether or not the NDIS has actually been helpful, particularly in children under 10. Because they're pushing and pushing for diagnoses which are made by individual clinicians who don't even know each other, and there's not that pooled assessment, and it's all privatised at $200 an hour. So until you separate it from fees, you're not going to be able to improve those systems. I wouldn't have it start until they're at least 10. And that would allow that more universal thing. Why can't we have universal early intervention where clinicians actually went to the children's homes and did part of their assessment there? I just feel like we've had some things, but we've thrown them out with the bathwater. Same thing's happening in the UK. They're throwing out the health visitors who are instrumental in looking after the mental health of families as well as preventing a lot of these things.
Yeah, so I'm not sure how to answer your question except data. We need data. If if you've got data, you become an advocate. Without data, you're just a lobbyist. And so we compete against all the other lobbyists. So that was one of the recommendations in the strategy, and it was made in the 2000 report as well. We really do need to start advocating for good data and evaluation built in. If we had good data to demonstrate the efficacy of all of those things that have been disbanded, government would have a harder task to dismantle them. As far as NDIS goes, I totally agree with you. I think that's the optimistic part of me, but NDIS is only a little bit of optimism, says it's such a huge program, inevitably you'll have teething problems. And I know there's a lot of advocacy coming from Victoria, particularly, trying to address those changes of diagnosis rather than family-centred practice, all the things that are wrong. The pessimistic part of me says it's just a bureaucratic nightmare, and we've set back children with additional needs by a decade because we dismantled a really good intervention service called ECIS and replaced it with a third-rate system. But I think we just have to wait and see. I do want to try and address Joe's problem. That's sort of gnawing away at me. And I don't disagree with you. You can easily paint a bleak picture of it. But we can't afford to be pessimistic. You know, we all have exactly the same ambition for young children. We know exactly what, it's not as if we're short of information, short of research. We know the difference good services can make. We know the difference families can make. We can't afford to give up. We can't afford to be pessimistic. For me, I work with colleagues, and so, you know, on bad days, they pick me up and we pick each other up, etc. But if not us, who's going to advocate for children? And somehow we just have to keep on finding a way. And you know, there are little promising changes. You know, the Chinese saying the journey of 1,000 miles starts with a single step. There's been lots of little single steps, and the problem is there's one step forwards, two steps backwards. But I really do see, I really am starting to see a change now, which, you know, I think the elephant has left the room. I think there's attention to children in a way there hasn't been for 5 or 10 years. And it's really up to us, and we can't afford not to grasp the day, not to grasp this opportunity, because the losers are going to be children.
Hey, Frank, Jen McIntosh. Now at the Bouverie Centre. I wanted to thank you for your comments about solutions for a modern age, and they've really got to look different to our past solutions. And I wanted to get some comments on the digital health space. You mentioned child and family hubs. So at the Bouverie Centre, we're building an e-family mental health space, and you've really inspired me to think about broadening how we're conceptualizing it. So at the moment, it's very focused on relational health resources and family therapy resources. So for children and multiple members of the same family to walk around a digital space together, and as needed, they guide themselves through to our walk-in telehealth service where they can see 3 family therapists in less than a 5-hour wait. So it's progressive, it's innovative, but you've made me realize it's actually very focused on a family therapy model, and where a community of practice could equally sit in a digital space. And I wondered, you're probably more aware of interventions in the digital space in that regard than I am, but your comments.
Yeah, there's no question the future mental health service system has a very large online component. I'm involved in 2 national research projects looking at online resources in some way. I know of at least a couple of others. Sharon and Harriet have a model in Wyndham. So there's work being done all around the country in that. I think that the research and the models are a fair way ahead of funding. I mean, there's danger to telehealth and Medicare item numbers, etc. So we have to bring the government along with us. And I think all that is moving so quickly. I'm not sure how it's going to land, where it's going to land, but certainly in 5 years' time, the mental health services landscape will be, if not dominated by online. That'll be a very large component of it. And that obviously is the solution for rural and remote families. You know, telehealth has been a godsend for them in a way that hasn't been before. So that's one of the reasons I'm a bit optimistic, Joe. There's all these little emerging things. The future does hold promise, and online has to be an important part of it. That's been one of the benefits, if there is a benefit, of COVID, that suddenly everyone's become comfortable with telehealth and online services in a way that wasn't the case 2 years ago.
Frank, we have another contribution.
Grania O'Loughlin writes, fantastic session. Thank you. At what age do we consider early intervention and prevention? Much of the focus seems to be at school age, 4 years plus. We are advocating for earlier intervention and prevention in infant mental health and toddler years. Identifying children with behavior issues at school is not early enough. How do we effectively advocate to government to focus on the even earlier years where prevention in the first 2,000 days is a significant investment in the child's trajectory?
I totally agree. In fact, early intervention should start at -9 months. Needs to start during pregnancy. There's no shortage of advocacy. I just focused on the program that I was involved in schools, but I'm not for 1 second suggesting that we should wait until we start school. And I think our centre's been at the forefront of advocacy around early years and early intervention. So we're on exactly the same page. How we advocate, well, I can't say we've got great success in advocating for early childhood either. No further questions.
Straightening out a technical issue there. Yes, there's a question here.
Sure.
I think you're probably wanting to wrap up, but I just thought I'd just throw to you, Frank, we've sort of skirted around the issue of equity, but I just thought it might be worth discussing that a little bit head on. And also, I guess the other elephant in the room around equity is many of us. So pediatricians, child psychiatrists, psychologists, the Medicare means a lot of people are out of pocket. And so we're kind of part of the solution and part of the problem at the same time in regard to equitable access. And I think it comes back to your comments about a prevention system that sits outside the medical and health system potentially. But I thought I might throw to you just maybe to talk about some of the issues around equity.
That's great.
Inequity.
Thanks very much. Yeah, it's a huge issue. And there was an article by Stephen Duckett in one of the New Daily, etc. He had to go and see a dermatologist, and he inquired how much out of pocket he was. And the dermatologist said he was charging 3 times the recommended fee, you know, and that's outrageous. But it's a private practice and governments can't control what they charge us. But I personally find that offensive, you know, like really outrageous. There do need to be more bulk billing clinicians. And I don't know what sort of incentives you provide. Are Medicare rebates too low? Maybe. But the public wouldn't wear increased Medicare rebates to address the gap, because they point to these specialists who charge $200 for people out of pocket, and they say doctors are very well rewarded. Why do we need to increase it? So I don't know what the solution is, but I'd be interested in your comments. Yeah, really. We've been advocating. I think collectively, we at the centre, both individually and collectively, have very, very impressive CVs of failed advocacy on a number of issues. And close to the very top of that tree is arguing for salaried paediatricians in Victoria. So most other states in Victoria have a publicly funded network. And usually paediatricians working in a multidisciplinary team. So a GP or a parent can refer a child to the team. They're seen by a paediatrician, psychologist, social worker, speech pathologist at no cost. And we haven't got that in Victoria. So that's a great example of how we just, despite our very best efforts over the years, we haven't been able to land that one. It's now up to you, Sharon, and Harriet and Daryl to do that.
Well, I'm afraid we're going to have to draw this discussion to a close as time is going on. I'm going to have to leave my question of you, Frank, to a private discussion. We're approaching our finale, and I'd ask you to keep your seat now for the MHYFVic President, Professor Joe Grimwade, to speak briefly and bring our evening to a conclusion. Thank you, Joe.
Thank you, everybody, for taking part in today. A project of 3 years gestation. It's supposed to be a project of 9 months, but you know, this one took a long time to get out of the formulation channel. We at MHYFVic is tries to do lots of things, but essentially we want to be able to make child mental health, family mental health, much more important in the lives of the families, but also in the lives of our society. And despite what might have sounded like a prediction about doom and gloom, I am quite a positive person. I do see lots and lots of people. I do use telehealth lots and lots and lots in my work. And I bulk bill, and I work for an Aboriginal mental health service as well. I think that we, MHYFVic wants everybody to start collaborating. And if there's any one thing that Frank has told us, that's what we need to do. Because if we start to work in a divided way, individualised way, we actually shut our minds off to those of others. And we really do need people to join us, join MHYFVic, but to join us in every project we work for. We do lots of projects. We want to develop and practice research and policy. We want you to read our newsletters. You can join us. We want you to join us, but you can still be on the email and look at our newsletters and see what we're talking about, see what we're thinking about. Come to these events. This is one event. We also started a one-year tradition of having a Universal Children's Day at the Children's Hospital at the end of 2019, but haven't been able to do that for the next 2 years. It was actually a fantastic forum that day. That was 50 years after the United Nations Charter of Children's Rights. And we want links. We want to be joined with people. And we want a bit of funds. We want to find out if we can run workshops that people want to attend and pay not too much money, a bit of money, so that we can continue to be as successful in our advocacy work. So we're $50, not much. You don't have to pay the $50. You can still be on our email list, but we want people to go to our website and pay on the website. We really want to be able to expand our activities. We really want to have more people involved. Is that the last one? Okay. If you want to see the quality of the work that's on our website, I think we can say that the thing that probably is most impressive after the Winston Rickards Memorial Oration is our guide to best practice, which seeks to bring together information, bring together the data on what works from prevention through to treatment, everything. Now, the chief author of this enormous project, which also includes policy and implementation guidelines, is Dr. Alan Maudsley. And it was Alan, who actually suggested that our orator could be, back I think about in 2017, we did have that we would like to be able to get Frank along at some stage when he sort of gets through that government thing that he's signed himself up for. And he wasn't ready. Well, the government thing he signed up wasn't really ready. But then we had COVID, and now we're pleased, very pleased, to have arrived at this point where a lifetime's work can be celebrated, to celebrate the lifetime's work of Winston S. Rickards. And I would like just to thank you, everybody. I would like to be able to present to Frank a small token of our appreciation to this. And I want to thank you all for being here. And everybody out there, thank you very much.